Hi, I'm Danielle Root. I'm an RN who's currently pursuing an MSN from Eastern Kentucky University. Today I'm going to share with you my findings when exploring the PICO question. In an outpatient hospital setting, how does the implementation of hourly rounding compared to standard care affect call light usage within a 6-month time frame? What is hourly rounding? Many facilities encourage their nurses to participate in hourly rounding on each of their patients. Often there's an area of documentation such as a flow sheet or a checklist in the electronic medical record where the RN can document that hourly rounding was performed. But what exactly is hourly rounding? Hourly rounding is a set of interventions of which the nurse is expected to see each patient at least hourly. During these interactions, the nurse is to assess the peace of the patient, or that is to say their pain, their IV pump, their possessions, their positioning, and of course the potty, which is toileting. The term paid for performance should not be a new concept to advanced practice registered nurses, as it includes provisions to improve patient outcomes and increase patient satisfaction. Hospital Consumer Assessment of Healthcare Providers and Systems, or the Hcap Survey, is a standardized publicly reported survey of patients' perspectives of hospital care. These surveys are sent to patients after discharge and contain questions regarding the care they received. Increased Hcap scores mean increased reimbursement to the facility. It's no surprise that healthcare corporations have made a push in recent years to be more client-centered. Many facilities have adopted the concept of hourly rounding in an attempt to increase patient satisfaction scores, decrease inpatient fall rates, and increase nurse satisfaction. Purposeful, effective hourly rounding is an intervention or set of interventions which can be useful in clinical practice. While pursuing the literature for hourly rounding utilizing CINAHL PubMed, I identified 2 Level 3 quasi-experimental design studies which were then critically appraised. The first study, Hourly Rounding, a replication study, was a recreation of a previous study performed in 2006 by Meads, Bursell, and Kettleson, which also used a quasi-experimental design and non-equivalent groups to study hourly and 2-hourly roundings for 6 weeks, where nurses and nursing assistants performed rounding addressing the piece of patient care. This study resulted in decreased call light usage and increased patient satisfaction. The replication study performed by Ulrich, Kallman, and Negolian in 2012 to determine the effect of hourly rounding on fall rates, call light usage, and patient satisfaction in an inpatient med-surg patient population also revealed a decrease in falls when utilizing rounding interventions. Call light usage in the first week reports a statistically significant decrease in call bell usage, but weeks 2 and 3 saw an increase related to a delirious patient on the unit. He was clearly an outliner, and removing him from the study showed significant change in call light usage. Patient satisfaction showed no statistically significant difference between pre-rounding and post-rounding, according to Hcap results. The second Level 3 research study was also a quasi-experimental design, which determined if there was an advantage to structured process for hourly rounding implementation through formal education compared to the standard train-the-trainer method to track improvement data on efficiency, quality, safety, and patient satisfaction. The structured process, or SHARP, targeted to ensure that hourly rounding was incorporated into the fabric of patient care and were structured to address staff education, patient and family awareness of hourly rounding, documentation, and coaching and mentoring. The study revealed a significant difference between the interventions group and the control group in call light usages. Similarly, day shift nurses reported a significant lower steps, and there was a decrease in patient falls. Hcap surveys also showed significant difference between the 2 units during the study. Here we see how some patients may perceive their experience with pushing the call bell. However, anticipating the needs of our patients through hourly rounding helps to decrease the use of call lights, thus limiting staff interruptions, decreasing noise on the unit, and also decreasing nurse steps throughout the day. It's clear how implementation of purposeful, effective hourly rounding into clinical practice could increase not only patient satisfaction, but nurse satisfaction as well. Hourly rounding is more than just a signature on a flow chart. While interventions are many, some of the most effective include top-down administrative support for systems change, education of nursing staff on purposeful, effective hourly rounding, as well as educating patients and families that the facility performs hourly rounding and what that means for them. Hourly visits from primary nurses who will assess the P's of rounding, leadership rounds, where a nurse leader visits each patient to get the views of the patient's unique experience, as well as to assess RN competency and accuracy of hourly rounding. And lastly, evaluation of the nursing staff's performance, follow-up instruction for those who weren't performing per protocol, and monthly staff meeting reinforcement that the facility performs effective, purposeful hourly rounding. During the literature review, several qualitative research studies also listed the use of scripting, where all staff use the same terminology during their hourly rounds to promote continuity and efficiency. Hourly rounding is practiced in acute care hospital settings. It's evident that the advanced practice registered nurse leader can be instrumental in improving the care of the patients on her or his unit, as well as increasing the nursing staff satisfaction.